Good morning. My name is Carlo Ercoli, and I am here on behalf and as a member of the Build Your Smile Foundation. I am with the University of Rochester in upstate New York, and I am proud to be one of the members of the foundation that last year, for a number of years, of course, have traveled to beautiful Uganda in order to provide some community service, as well as to be with you in Kampala for our symposium. Unfortunately, this year, we were not able to travel for obvious reason related to COVID, but we look forward to being here as soon as possible and to meet you again, our friends, in such a way that we can rejoice once again in our camaraderie. Today, Dr. Isaac Barzilai has asked me to discuss the effect that dental prosthesis might have on the periodontium. And this is a topic that's very dear to me, as I and my group have done a fair amount of work in this area. In fact, when we look at this topic, we can see that we started doing this work not only out of our passion, of course, for the relationship between prosthesis and the periodontium, but also as part of the 2017 World Workshop on periodontal and peri-implant classification. I was one of the members, and I was very lucky to contribute to this worldwide effort. That effort produced a number of papers, among which there were about 4 published in the Journal of Periodontology, as well as in the Journal of Clinical Periodontology, that outlined some of the findings, some of the consensus that we achieved. At the same time, we continue our work, and just last year, we also published an additional paper specifically on the effect of fixed restoration and on the periodontium. So today, my talk will mostly be based on the findings of this work. Of course, for obvious reason of time, we are not going to be able to discuss everything, but we will pick certain topics that are certainly important to us, and I hope will be useful for you. So when we look at the topics we're going to cover in today's lecture, we're going to look at removable dental prosthesis, partial dentures. We're also going to look at fixed dental restoration, including fillings, crowns, veneers, and we're going to look at them specifically for the effect that they might have at the level of the gingiva. We're going to discuss a bit about periodontal phenotype, how the characteristics of the periodontium actually affect the behavior of the gingiva when we place crowns or veneers or other restorations. And we're going to discuss as well as far as the biologic width. So the outcomes, the thing, of course, that we don't want to see after we deliver a restoration is the onset of gingivitis and certainly of periodontitis, which certainly we know will lead to a progressive loss of attachment, recession, pocketing, and certainly potentially the loss of the tooth. So these are adverse events that we like to avoid. So if we are to start this conversation today, we will start with removable dental prosthesis, partials. Now, generally, we try to design our partial as much as possible with a metal framework, but we know that it's not always possible. And sometimes, we need to incorporate perhaps a major connector that's made out of acrylic. So the entire partial denture is made out of acrylic. Well, if that is the case, of course, we need to make sure that our acrylic restoration, our acrylic partial is strong enough. But at times, of course, given the property of the material, it might be hard to make sure that the material is thin or perhaps doesn't cover much of the periodontium. Now, if we do, however, have the possibility of placing or fabricating a metal framework, this becomes much easier. And of course, once we look at the design of a metal framework, the one thing that immediately comes to mind is the coverage of that major connector of the periodontium. Now, we know, and it's been pretty much established, that all other things being equal, we will want to make sure that our major connector is resistant, is rigid, yet it covers the least amount of gingival tissue. For obvious reason, of course, because it will allow the patient to perform oral hygiene and just a natural cleansing of the food and liquid that we put in our oral cavity will also contribute somehow to plaque removal. So whenever we look at major connector, of course, the purpose is to make something that is simple in its design, yet rigid, that does not have any particular design that might be plaque retentive. So, for example, something that is like this, although might be somehow artistic in nature and might delight our colleagues in lab technology, it is certainly not rigid and is certainly not cleansable. And especially if we look at this restoration where we have a, I would say, very artistic type of design, we know that, however, that is not simple and certainly it is not rigid. So I will suggest that we do avoid this very fancy type of design and we keep it really with simplicity. In fact, when I first came to the States, one of my mentors told me about KISS. Now, we all know about KISS, and when we kiss and we love each other. However, in this case, is keep it simple, stupid. So let's not complicate our life unless we absolutely have to. Now, when we look at removable prosthesis, often we get confused with what we call association study, cross-sectional studies, where we look at a population and let's say we see the presence in that population of a number of variables. Very simply put, if we look at a section of the population that perhaps is 70 years old, we can quickly see that in this population, we will have, of course, a individual advance with age, as we said, about 70 years old. And most often than not, more often than not, we'll find that this person has white hair. Now, in an association study, you cannot really say that one is causing the other. Of course, this might appear like a silly example because we all know that it is old age that causes white hair. However, in the studies, you might as well say the opposite. So again, anytime that you see in a study that one factor is associated with another, it does not really mean that one factor is causing the other to be present. Okay, and this is a very important distinction. So, and we look at removable prosthesis again, a number of association studies will show that if you have a partial, your periodontal condition might look worse. However, when you really look in details at more valued studies, perhaps longitudinal studies, you can clearly see that what is important is the basics. And what are the basics? The basics is the ability of the patient to maintain a healthy periodontal condition. So again, decrease plaque accumulation and certainly, if possible, attend periodic dental appointments in such a way that we can take a look at those areas and give feedback to the patient as far as the areas that are either clean or not clean. In fact, when we look at studies that have more value in terms of establishing potentially a causal association, a cause and effect association, we see that if periodontal disease is treated and patients have an adequate plaque control, realistically, there is no negative effect of a removable partial denture on the periodontal condition. Now you might say, well, this might happen only in controlled condition, perhaps in a university setting, but I don't see that happening in my practice. Well, this is a practice-based research, meaning a research that has been carried out in the offices of dentists and exactly find the same results. Meaning if your patient, if my patients do not attend periodic checkups, do not pay attention to the periodontal condition, one day, yes, there is a deterioration of the periodontal condition. But again, this is not related to the wearing of a removable denture, of partial denture. It is related to the fact that the patient cannot maintain the periodontal condition. Now, if we switch topic and we look at direct restorations, let's say fillings, amalgams, composite, glass ionomers, there are a number of things that we can look at, like, for example, the position of the margin. Is it above the gingiva or it is within the gingival sulcus? It is overhanging or not? What type of dental materials might cause more of a periodontal problem and what materials may not? And then we're going to look at periodontal biotype and certainly what we call supracrestal attachment, in other words, the biologic width. Now, when we look at direct restoration, again, in association type of studies, we seem to see the same result. The presence of fillings with an intrasulcular margin, a subgingival margin, is associated with a worsening of the periodontal conditions. This is more apparent also when we have overhangs. We all know what overhangs are. Is a misfit, is an excess of material that really extends beyond the cavity preparation for the filling. Now, interesting enough, however, when we look at overhangs, first, they are extremely common. About 60 to 70% of fillings that are done by dentists around the world have overhangs. However, they are not all created equal. Large overhangs, like you can see on the upper right corner of the screen in the two pictures on the upper right side, are certainly something that we will not want to do. However, the one on the left, which perhaps is smaller than 0.2 millimeters, seems not to be a problem in terms of worsening of the periodontal conditions. Now, the other part, of course, which are the materials. Are they all equal? And we know from lab studies that a number of ions, a number of materials may be potentially detrimental to the functioning of some cells. But of course, there is a big gap between a lab study that's looked at cell function and, of course, what we might see in our clinical practice. So the relationship is actually fairly unclear. So often we have to resort to large epidemiological studies that look at thousands of restorations to see if some of these restorations are actually detrimental to the periodontium. So in this study that actually in Brazil, relatively recent, about 30,000 restorations were seen. And one of the two outcomes that were measured was the presence of increased probing in the periodontium and what we call clinical attachment loss, which of course is the hallmark of periodontal disease. So what was seen is that, yes, fillings did correlate with the presence of worse periodontal condition. However, when the data was really analyzed, it was seen that only fillings that were made out of amalgam were the responsible one, while fillings made out of a composite did not seem to have any negative effect on the periodontium. In fact, in this extremely well-done study by some of my compatriots in Italy, it was seen that as far as the patients maintain a good oral hygiene, and we will respect the biologic width, and we will expand on this concept later, the making of a direct restoration out of composite was completely compatible with periodontal health. And in fact, this is also true with other adhesive restoration, like, for example, resin-modified glass ionomers or other types of material. So if you place these materials on a tooth, realistically, the tooth or the material behaves exactly like the tooth structure, meaning that if the patient brushes his or her teeth, no gingivitis, no periodontitis will occur. But similarly to what happened to a natural tooth, if the patient does not maintain a good oral hygiene, the material, of course, will accumulate plaque, needless to say. Now, if you look at indirect restoration, in this case, we mean crowns, veneers, bridges, something that, of course, it's not directly done chairside by us. Again, some of the similar factor that we previously discussed for direct restoration of fillings will apply. And we're about, of course, to take a look at them. Once again, if we look at association studies and we look at crowns with subgingival margins, it does appear that these crowns are associated with worse periodontal condition. However, again, if we look at prospective studies, studies with more value from a cause and effect standpoint, studies in which the patient were actually instructed on how to clean their teeth and how to maintain their teeth healthy, we see really that there was no difference between teeth that receive crown and teeth that did not receive crown in terms of a worsening of the periodontal conditions. And this is probably clearest when we do, for example, porcelain veneers. If we do veneers, like in this situation where we have perhaps wear of the dentition, and we are going to prepare those teeth for some porcelain facing and deliver those restoration, we can see that not only the veneers are beautiful in terms of aesthetics, but also appear to be quite compatible in terms of periodontal health. At least clinically, the tissue looks quite healthy. Now, similarly to what we discussed for direct fillings, overhangs are not all created equal. In fact, we may have small overhangs within 0.2 or 0.5 millimeter that seems to be compatible with good periodontal health, while larger overhangs are not, and may cause gingivitis, may cause redness, inflammation, and bone loss. Now, does it mean, however, that this is it, that we don't have to worry about anything else? And the answer is no, because one of the most common consequences of fixed restoration, especially crowns, is that over time, some of that gingiva that surrounds our crown that looks beautiful actually may have a tendency to recede, to cause a periodontal recession. As you can see in this clinical photo, one of our students, where a beautiful set of porcelain crowns and veneers were delivered, but you can see that after several weeks, again, the presence or the occurrence of periodontal recession has exposed part of that tooth structure below the crown, which of course has a different color. So if we are about to embark in a large restoration or even the placement of a single crown, in this case, we did a full arch rehabilitation. This was one of our students. We need to take, of course, an impression, either digital or analog. And we need to make sure that that impression really records not only the prepared tooth structure, but also the margin of that restoration. So more often than not, we will employ some measures of gingival retraction procedure. Now, when we do gingival retraction for the purpose of capturing the edge, the margin of a tooth preparation, effectively we need to achieve a reversible and gentle displacement of that gingiva in such a way that we can record that margin, but then again, make sure that that gingiva goes back exactly in the same place. Now, what are some of the modalities, some of the instruments that we can use? Well, majority of the dentists will use cords, either one or two in combination, perhaps with some chemicals. There are pastes that are used that expand and it tends to push the gingiva away. And then there are surgical measures, like, for example, electrosurgery, or can be a laser. And of course, we can have combination of all of this depending on our clinical indications. Now, the goals of gingival retraction is to be kind to the gingiva. We don't want to just to casually or roughly put pressure on that gingiva because we may cause, again, a recession, but also we need to be effective. We need to make sure that our lab technologists can actually see that margin. Regardless if the margin is assessed, is defined with an analog measure on a cast, like you can see on the right side, or with some digital software, like you can see on the left. Now here, I'm proud to recognize one of our former students, Dr. Einarsdóttir, originated from Iceland, which did a beautiful clinical study in which she compared different means of gingival retraction. A paste, like you can see on the left, a single cord, like you can see in the middle, and a double cord, like you can see on the right side. Her goal was to see how easy it was for the lab to actually identify the margin, and at the same time, how often this methodology will actually cause recession of the gingiva. Now, here again, there is a third factor that we need to really pay attention to. Is not only the material that we use, the tooth preparation, and the equipment that we use. but it's realistically the characteristics of the periodontium. In fact, we know that gingiva can come in different thickness, like you can see right here. This is a thick gingiva, which really lends itself very well without causing a recession to a number of things, including gingival displacement during crown preparation and impression. It is very much different in a situation like this when we have a thin periodontium, a very thin gum that really is much more susceptible to recession, no matter what we do, than, of course, a thick gum. So realistically, we're talking about the periodontal phenotype, which is really the combination of the dimension of the gingiva, both in terms of thickness and in terms of keratinized tissue, and of course the underlying bone, how thick the buccal bone will be. Now, needless to say, a thin phenotype is one in which we have a small amount of gingiva, a small thickness of that gingiva, and certainly a very small, a very thin buccal bone. So, for example, if you look at this situation, it is clear that this is extremely thin phenotype, because you can almost see the tooth intransparencies below the soft tissue. So it is extremely important in this case is not to be aggressive in your surgical procedure or in your gingival displacement procedure, because likely this tissue will react with a recession, okay? And this, of course, brings me to what is below the gingival margin, which is the biologic width. Now, the biologic width is the summation, is the area which is described by the epithelial attachment, which is right apical to your gingival sulcus, and the connective tissue attachment, which is really apical to the epithelial, the junctional epithelium, but is coronal to the tooth crest and sees the insertion of fibers that are part of the periodontium. Now, generally, this area is defined or is described as measuring about 2 millimeters. But let's remember that these are average values. That means that these are values that are average within a population. However, as you can imagine, we're all human beings, and we don't come really with mean values. We're all a little bit across the board. So we know that biologic width, which most properly should be called supracrestal tissue attachment, varies by tooth type, by surface. If the tooth has had loss of attachment, like periodontal disease, if you had a crown, perhaps, or crown lengthening. So there are a number of variables that really affect the dimension of the biologic width. Now, what is an invasion of the biologic width? An invasion of the biologic width is when, with our instruments, but especially with our crown margin, we extend within that either the epithelial attachment or worse, within the connective tissue attachment. Now, don't get me wrong. If you, with your burr during crown preparation, detach slightly the epithelial attachment, that's certainly okay. That attachment, provided that it is not covered by your crown margin, will simply reattach. But we must be very careful and certainly very cognizant of the position of the connective tissue attachment so that we don't traumatize that area, and certainly we do not extend our restoration in that area. Now, if we do, what could occur? Well, generally we will come up with often a recession of the gingival margin, an inflammation and a remodeling of that connective tissue attachment, perhaps of the bone when it is thin. And this occurs mostly in the anterior area, where generally we will need the least, of course, for obvious aesthetic reason. So we ought to be particularly careful, again, in respecting this area, certainly during our procedures. Now, as I said before, if you just disrupt a little bit the epithelial attachment, either with your burr or during your gingival displacement procedure, it's not the end of the world, provided that you do not place a margin of a restoration in that area will likely reattach without any problem. But again, we need to avoid to extend that margin within the connective tissue attachment. So in conclusion, actually, of this section and actually of the lecture, the biologic width really should be called supracrestal epithelial and connective tissue attachment. It is highly variable. It is not the same in all of us. However, we do know that an invasion of this area by our margin will likely cause recession, crestal bone loss, and a migration of the connective tissue attachment. So we certainly want to avoid this type of restoration. Now, as we conclude this lecture, I guess the message that I'd like to send you is the fact that although we are fabricating crowns, partial, mechanical structure, we really are working in a biological environment where we need to be aware and knowledgeable of the biological reaction that we might potentially cause. So we need to understand this area, and we need to make sure that we do understand that there is a periodontal complexity and variability with our patient that has to be considered before we actually proceed with our restoration. Having said that, I would like to thank you all for your attention. As I said, I wish I was there together with the Build Your Smile team. We do really look forward. We can't wait to be back in Uganda with you, our friends, and to be able to see you all again. I am going to now end this presentation, and most likely I will entertain some questions, should there be some from you. Once again, it has been a pleasure and it's been an honor, of course, to be here today, and we look forward to see you again.